Hi, it's Nursing with Hart, PhD again. This is a short content on mental health nursing, ethical and legal issues. This is mostly the ethical terms that I'm going to go over on this content. These are some of the most important ethical terms that you should know. These are going to be on your mental health exams as well as possibly on your NCLEX. So let's get started. Okay, autonomy. Autonomy is simply the patient has a right to make choices. Okay. Autonomy emphasizes the right of patients to determine their own destiny and assumes that individuals are capable of making choices for themselves. Beneficence, okay, the duty to benefit or promote others, the good of others. These are nurses who act in the interest of their patients, are beneficent. Think of the word benefit, right? So we're, as nurses and healthcare workers, we're one of our oaths of practice is to benefit others and promote the good of others. This includes knowing when to act on a patient's behalf. For example, acting on your patient's behalf would be, for example, if a patient is taking a certain medication and they're having too many side effects from it and they stop taking it, you may want to advocate for your patient and call the doctor. Say if it's a blood pressure pill, for example. There's so many different blood pressure medications on the market that you may call the doctor and say, Doc, my patient so-and-so is taking this medication and they're complaining that it's dropping the blood pressure too low or whatever the side effect is. You may want to ask the doctor, can you take a look at something else and try a different medication for them? Okay, that's where you're advocating for your patient. Non-malfeasance, okay, this is the requirement of healthcare workers to do no harm to their patients, okay? We are required to do no harm. We're abstaining from negative acts toward another person, meaning your patient. Justice, okay, justice is equal rights for all, basically, justice, regardless of race, sex, marital status, diagnosis, social standing, economic level, or religious belief. So, for example, unfortunately, some injustice things do happen in our country. For example, if someone is, let's say, on the list for an organ transplant, it should be that everyone should have equal rights and abilities, right, to those resources. And no matter what your economic status is, okay, or religious beliefs, justice has to do with the rights regardless of race, sex, marital status. So my PhD dissertation was on the topic of the LGBTQ community, and they have rights to, just like everyone else, no mattering their sexual orientation or their sexual preferences. Veracity, okay, is the duty to be truthful. If you're going to say to your patient, I will be back in 15 minutes to take care of your wound care, whatever it is, try to be back. Try to be honest and truthful and try to be back in that amount of time. Okay, right to treatment. Everyone admitted to the hospital or any other facility has the right to treatment. Right to refuse, including medication. So this is specifically what I want to talk about, is ethical issues in the psychiatric mental health units or hospitals. Patients always have the rights in any other units, but they also have rights in the psych unit. Okay, patients who are in the psych or mental health unit. Even if they're involuntarily committed, I'll say this again, even if your patient is involuntarily committed, they still have patients' rights. They can refuse labs. They can refuse to get their vital signs taken, their blood pressure, pulse, everything else. They can refuse to take their medications until or unless they are considered to be at a risk of harming themselves or others, and that's when they lose their patient's rights. Okay. So, for example, if a patient, and I've seen it many times in the psych unit where I was taking my students, patients have rights to refuse medications and treatments, but if the psychiatrist has determined they are at risk of harming themselves or others, if they begin to act up and get aggressive with another patient or with a staff or healthcare worker, anyone else in the unit, that's when the nurses and doctors have the right to step in, okay, and they will encourage the patient to take the medication. It's usually an injection that will help them to calm down and get out of that situation. In the unit that I took students to, I rarely saw them hold anyone down. I rarely even saw them put hands on the patients. But if they had to, they did. They would do a physical hold. They didn't use restraints, wrist restraints, or anything like they do in the hospitals, but they did do a physical hold if they had to hold the patient in order to get the injection in the arm or the hip in order to help them calm down. So that's a little synopsis of how patients' rights refer to people in the psychiatric mental health units. Patients in a psychiatric mental health care also have the right to the least restrictive treatment alternative. In other words, if they are able to be treated in an outpatient setting, they have the right not to be hospitalized. Okay, if they are hospitalized, they shouldn't be sedated, restrained, or secluded unless less restrictive steps were unsuccessful. In other words, the nurse has to try talking them down. They have to try and ask them if they'll take a medication. They have to try different means before they can't go right to restraints. They can't go right to physically holding the patient. They have to try different things, different steps. Once those are unsuccessful, then they can go to the other attempts. Okay, right to confidentiality and privacy. These are HIPAA laws. That's a federal law that has to be followed by healthcare workers. Okay, the exception here is the duty to warn. Okay, and the duty to warn is protection of a third party established by a court case in 1974. This is the rule that a mental health professional has a duty not only to their patient, but also to individuals who are being threatened by that patient. Most states now recognize that therapists have legal obligations to prevent their patients from harming themselves or others. Okay, so in other words, if a therapist is in a therapy session with a patient and they state, I am going to kill so-and-so, or I'm going to harm this person, and they name the person, that therapist has a duty to call the authorities and report that complaint, and that is not breaking HIPAA laws. Okay, they have a duty to protect not only their patient, but other people. Okay, informed consent. This is the preservation and protection of an individual's right to decide whether to accept or reject treatment. There are times when treatment may be performed without obtaining informed consent, but in most cases the nurse must ensure that 3 major elements of informed consent are addressed. The patient must have the knowledge. This means that the patient has received adequate information on which to base their decision of whether or not to have the procedure. Competency. The patient's cognition should not be impaired to the extent that would interfere with their decision making. If so, the individual should have a legal representative. And free will. The individual has given consent voluntarily without pressure or coercion from others. Restraints and seclusion. So in the psych unit where I was taking the students, they don't have restraints and all that. They don't use them. I asked one of the nurses if they had wrist restraints. She said, no, we don't have those in this unit. They don't use those kinds of restraints. So that, like I mentioned before, they use generally a physical hold only if they have to. Okay, so in the hospital, these are leather restraints. You should be learning in your skills lab about restraints, how to apply them, okay, and what the safety issues are there. Staff should be trained and competent to minimize the use of restraints and seclusion when use is indicated to use them safely. So seclusion units, they have seclusion units in the psych unit. They have 2 of them. They are single rooms with a single bed, no sheets, no pillows, no blankets on the bed. Okay. These rooms are generally used, say for example, when the patient first comes in and they are considered to be at a high risk of a suicide attempt. They're placed in that safe room until the psychiatrist comes in the next day to assess them. Okay, and this is each room has a door. The door can be closed and locked. Okay, lock slides across. There is a window where the tech or the nurse can monitor the patient 24/7, 24 hours a day until the psychiatrist comes to make their assessment. The only time I saw those rooms used, they actually had the door open, because then there's another door to the hallway. So there's 2 doors. There's a door in the hallway, and then there's a door into each seclusion room. So they didn't actually lock the door. They can if they have to, but it's not a padded room like you see on TV. A lot of things you see on TV just are not true, okay? They're not realistic. So that's about seclusion rooms. The seclusion or restraint is discontinued as soon as possible, regardless of when the order is scheduled to expire. In other words, the doctor is going to come in to assess the patient. If he lifts the order, the patient is allowed to come out into the community with the other patients. Sometimes I even saw a patient who was allowed to go in there, say if he was in a bipolar, in his manic phase, and he or she was being overstimulated by the other patients. They volunteered to go in the seclusion room, and they could just leave the door open, and they could have some quiet time by themselves, so they're not so stimulated. Unless state law is more restrictive, orders for restraint or seclusion must be reviewed every 4 hours for adults 18 and older, every 2 hours for children, adolescents aged 9 to 17, every 1 hour for children younger than 9 years. An initial assessment of the individual who is at risk for harming himself or herself, staff, or others includes identifying techniques to help the individual control his or her behavior, any pre-existing medical conditions such as dementia, previous drug overdose, physical disabilities, or other limitations that might place the individual at greater risk during a restraint or seclusion. History of physical or sexual abuse or other trauma, and their preferences about whether they would like family notified in the event of an episode of seclusion or restraint. Patients who are simultaneously restrained and secluded must be continuously monitored in person by trained staff. There must be enough staff to sufficiently supervise patient. In other words, you can't say, oh, we were understaffed, so we couldn't watch that patient who was in the seclusion room. No, that's not going to work. You're literally going to be fired on the spot, and you may be the patient can press charges against you. So you have to be careful about following the rules. Rules are very serious about restraints and seclusion. After the first hour, a person in seclusion without restraints may be continuously monitored through simultaneous audio and video equipment if consistent with the individual's condition and wishes. Staff who are involved in restraint and seclusion are trained and competent to assess the patient at the initiation of restraint or seclusion and every 15 minutes thereafter, including assessment for any signs of injury. Proper application of restraints, nutrition and hydration, circulation and range of motion, vital signs, hygiene, elimination, physical and psychological status and comfort, and readiness for discontinuation of restraint or seclusion. False imprisonment is the deliberate and unauthorized confinement of a person within fixed limits by the use of verbal or physical means. Healthcare workers may be charged with false imprisonment for restraining or for secluding against the wishes of the patient, anyone voluntarily admitted. Okay, so be very careful. Follow your facility protocol. So if you have someone in restraints, they have to be allowed to get up to go to the bathroom. They have to be allowed to eat. In the seclusion room, there's a bathroom right outside the 2 rooms. There's a restroom right there. You let them out to go to the restroom, and then put them back in the seclusion room. If you have wrist restraints, take off the wrist restraints. Give them range of motion. Do range of motion exercises with them. Okay? If they are complaining of numbness and tingling of the hand, you have to take off restraints and assess them. You have to do peripheral pulses, because if those restraints are restraining circulation, right? Here's the restraint on the wrist. If they're losing circulation, you can be in a lot of trouble. So you have to take off the restraint, range of motion, okay, and do physical assessment of peripheral pulses, okay, radial, brachial, all of that. Okay, so in Joint Commission, if they have to get involved, they have very specific standards for the use of seclusion and restraints. And if they do an inspection, okay, you better be following the rules. And I mentioned false imprisonment. Healthcare workers can actually be charged with false imprisonment for restraining or secluding against the wishes of the patient or anyone voluntarily admitted, okay? If they are not at risk of harming themselves or others, okay? And it has to be documented. Everything has to be documented in nursing. Document all the things that you tried. I attempted to talk the patient down. I attempted to do this, then I attempted to do that, and then I have called the doctor and I got a verbal order for restraint. But guess what? You have to get a written order when the doctor assesses the patient as soon as possible. Get a written order, okay? And then the assessments have to begin. Okay, patient has to be assessed while in restraints or seclusion. Very important. Okay, hospitalizations, there's voluntary and involuntary in the psych units, mental health hospitals. So the voluntary admissions are just what it says, they're voluntary. This individual makes an application to the institution for services, and they can stay as long as treatment is deemed necessary. In other words, as long as insurance is going to cover it, right? In our country, insurance typically determines how long they will pay for treatment. He or she may sign out at any time unless it's determined that he or she is harmful to himself or others. Himself, herself, or others. There may be instances of involuntary commitment of an individual. If this happens, the process must be conducted with federal and state laws in mind. Emergency commitment should be sought when an individual displays behavior that is clearly in imminent danger of himself or herself or others. In other words, plans to hurt themselves or others. These commitments are time limited, and a court hearing must be scheduled to decide if the patient should be discharged or if additional hospitalization is necessary. Involuntary commitment for mentally ill individuals in need of treatment may also occur. Most states have established their own guidelines for which constitutes mentally ill. Generally, this is defined as someone unable to make decisions for themselves regarding treatment, someone likely to harm themselves or others, or someone unable to fulfill basic needs. The involuntary outpatient commitment is a court-ordered process used to compel a person with mental illness to submit to outpatient treatment. Eligibility criteria for involuntary outpatient include a history of repeated decompensation requiring involuntary hospitalization, the likelihood of deterioration requiring inpatient commitment, the presence of severe and persistent mental illness, risk of becoming homeless and violent or suicidal. If it's determined that an individual is gravely disabled, a guardian, a conservator, or a committee will be appointed by the court to ensure the management of the person. Gravely disabled person is where the individual, as a result of mental illness, is in danger of serious physical harm resulting from inability to provide for their basic needs. In other words, they're not showering, they're not taking care of themselves, and they need some help, okay, with a court-ordered person. Okay, a nurse or healthcare worker can actually be charged with breach of confidentiality for revealing aspects about a patient's case or revealing that an individual has been hospitalized. So if you have, say for example, you're working in a mental health unit, the phone rings and you have to answer it because the charge nurse is away from her desk. And it's someone on the other line asking, is my cousin there? Is my husband there? I need to speak to them. Okay? And so you would put them on hold, check the computer for consent. If you don't have consent, you would get back on the phone and you would say the following: I'm really sorry, but I am not able to confirm or deny if this person is here. Click and you hang up. End of discussion. Okay? Don't even give them a chance to say, but, I know they're there. I just want to talk to them. So I cannot confirm or deny. Hang up. That way you're protecting their right to privacy. Okay? Defamation of character. A nurse can also be liable for defamation of character for sharing false or malicious information that is detrimental to the patient's reputation. When the information is in writing, it's libel. When it's the spoken word, it's called slander. Invasion of privacy. Charges can come from searching a patient without probable cause. Assault comes from a genuine fear that a person will be touched without consent. And battery is the actual unconsented touching of another person. Harm or injury doesn't have to necessarily occur for these charges to be legitimate. A nurse can be charged with false imprisonment for holding a patient against their wishes outside of an emergency situation. Okay, and these are the ways that nurses and healthcare workers can avoid legal issues. Okay, effectively communicate with your patient. Accurate and complete documentation in the chart. Very, very important, because guess what? If the client hires an attorney and the case goes to court, you as the nurse can be called to testify. And the lawyer representing the client will ask you questions, and they can have access to your chart documentation, and they may ask you questions such as, for example, it says in the record here, according to your notes, because it has your name on it, the date and time stamp, according to the chart's records, you state nursing will continue to assess. The lawyer I'm telling you, the lawyer is going to ask you, what does that mean? That doesn't mean anything. Nursing will continue to follow up. Nursing will follow up. Nursing will continue to assess. That is too vague. It's not detailed enough. Your notes have to be detailed with your assessments that you conducted, the interventions you conducted, dates, times, everything, and the patient's response to those assessments and interventions. Okay? If you comply with the standards of care and you have to be called to court, okay, you will do much better if your records are complete. Know the client. Make sure you follow nursing the hospital protocol, hospital facility policy. Okay? Practice within your own scope of practice. All right, that's it for today. That was a lot more than I thought it would be, but this is all good information that you can be tested on. These questions may be on your standard. I've seen them on standardized tests, ATI, Lippincott, all of those benchmark exams. Okay. Unit exams for mental health, and also NCLEX. I had students report back to me and communicate with me that they had many mental health questions on their NCLEX. They also had questions about psych medications, which I'll cover. They had questions about nursing interventions, bipolar, eating disorder, schizophrenia, which I'm going to cover, anxiety disorders, bereavement, grief and bereavement. Okay, I'm going to cover all of those topics. All right, so watch out for my new YouTube channel, Nursing with Hart PhD, and I will have that content on there. All right, have a great day.